Dr. Kim, thank you so much. That was truly an exhaustive talk. Um, but I can see that the field of hepatic malignancy treatment has evolved so much in the last decade, and I know we can actually all feel those changes, and we're able to make differences in these patients as well. So with that note, let me open for discussion. I'm sure there are a lot of questions from our audience. I see Dr. Abbas, his video is on, so Dr. Abbas looks like he's going to ask the first questions. Please, Dr.
Okay.
Abbas from
And thank you, Sanjay, and thank you, Kim, for this excellent presentation. And I am really impressed about the versatile sort of research that is being done at your center and the concept of IO. So, related to this concept, we are not always sure whether to give radioembolization before the checkpoint inhibitors, or should we give the checkpoint inhibitors before the radioembolization? What is your take about that and about the uh, CAR T therapy, that is intra-arterial CAR T therapy? So, what would be the risk of cytokine release syndrome in our patients who already have cirrhosis of liver if we subject these patients to CAR T therapy?
Yeah, so I think it was a twofold question. So first one, if I understood correctly, what would be the ideal sequencing of IO and the local therapy? Is that correct?
Yeah.
Yeah, and then the second thing is side effects potential of the CAR T for the liver cancer patients. So
Yeah.
the first one is probably a lot simpler. I do not know if there's definitive data, randomized data that can show one better than the other, because pretty much people usually set with a one sequence and go with it. People do not necessarily study two different sequences. But in my mind, and that's how I do, but in my mind, I think it makes sense to start IO, particularly one or two doses, and then you add the system local therapy following it. I think from a biological standpoint, that makes sense because by then the antibodies are tuned up to receive the more added effects from the local therapy, rather than doing it in a cold bed. Now, of course, the next step is what to do with the so-called cold tumor. Is there a way that we can excite the cold tumor in addition to the hot tumor? That's a sort of a different topic altogether. But in general, for all the patients, if I have a way, I would favor starting IO first, one or two doses, and then add the local therapy, and then continue with systemic therapy.
Because there is always a concern because immune therapy starts working in about 2 to 3 weeks. Like the good effect of immunotherapy, like atezolizumab and bevacizumab, if we give to our patient, then it takes some time to get the effect of that therapy. And if you give the local regional therapy first, then it is said that maybe the proponents of this take is that release of the tumor cells that are now become more responsive because of the change in the antigens that they have after the interventional therapy. They become more prone to be having better response to the immune therapy. So this is not clear to my mind. That's why I asked.
Yeah, so we can talk a lot about the biologically what makes more sense, because you can make an argument one way or another. Both you can supplement with the some plausible the data as well as the innuendos. But the I don't know if one is definitively more correct than the other. And but in research setting or in clinical trial setting, I think most of us have gone through the route of starting one, maybe two doses of IO followed by local. That's what we have been doing in many of the clinical trials. Now, in practical terms, in practical sense, in the United States, of course, everything needs to be pre-authorized and so on and so forth. So as long as both therapies can start within a short period of time, typically patients gets on the first. Now, practically speaking, because I've done both in unintended necessarily, I don't know if it makes a huge difference on HCC population. I think melanoma and so on maybe a little bit. Now, in terms of a second question on the potential side effects of the CAR T, so the answer is we know nothing about it. There's some data, particularly from China, in terms of a CAR T for HCC, but in the United States is really, really in infancy. A lot of data is coming from the animal data. So in terms of a cytokine, the storm and so on, we do not have data on that. But even at that, we hope that I hope that in a more targeted intra-arterial or the intratumoral CAR Ts can potentially reduce that of overall cytokine storm effects, but that's currently hypothesis.
Thank you, Dr. Abbas. Those of you who don't know, Dr. Abbas is from Pakistan, is a prominent hepatologist there. Thank you, Dr. Abbas, for joining as well today. Let me ask Dr. Rup Jyoti Datta. I think he has a question in the chat box as well. Dr. Datta, you want to ask the question yourself? I think the question in the chat box that Dr. Datta put it is, what temperature cryotherapy is accomplished? I believe that's, and he's from Dibrugarh, Assam in India.
Yeah, so
Dr. Datta. Dr. Datta, thank you for joining.
So if I heard it correctly, what would be the ideal temperature of the cryotherapy? Is that what was the question? Yeah. So there's a threshold that you need. I'm a little bit at a loss at the moment, but it needs to be minus below minus 20 degree Celsius. In fact, it's all set up in a machine of a cryotherapy where once you start the therapy, it goes all the way down to minus, I don't know, maybe like 100 degrees or something. So it's not just 0 degree Celsius. You need to drop it quite a bit, because what that does is that it actually stuns and kills and make a bunch of supposedly pores, micropores in the cell membrane, which causes during the cycles of thawing, that it rapidly increases osmotic pressure across the cell membranes, so that the cell death actually occurs. I guess depending on the machine, the temperature setting might be a little bit different, but it needs to be many negative degree Celsius temperature.
Thank you, sir. So nice of you.
Thank you, Dr. Datta. May I invite Dr. Jalal now to the discussion forum. Dr. Jalal, please.
Thank you. Really appreciate it. It's a great talk. The HCC, in unique thing about liver disease is that it's two disease. One is the cancer, other is the liver function, liver underlying disease, liver. In your experience, what's the major cause of death with your vast experience in these HCC patients? Do they die because of metastatic disease with tumor burden, or because eventually liver fails?
Yeah.
Yeah, go ahead.
Yeah. So that's a great question, and that's something that we struggle with all the time. The concept that hepatologists understand the best, right? But other people are catching up as well. But from my experience, the most well, let me take two different things. So if tumor treatments are successful locally or systemically, they all die of a liver disease, right? Essentially, that's the course of their. But the patients whose liver cancers cannot be controlled, if it's a limited, then usually they do not necessarily affect the tumor itself, sorry, the survival itself. The few patients that I had shown on the top of my lecture, those are the only patients that we think that perhaps dying of liver cancer. So we are talking about very extensive cancer, the multifocality of a cancer that actually affects the deterioration, decompensation of a liver. They are the ones who are supposedly dying of a liver cancer per se. So I don't have the numbers with me, but overwhelming majority of the patients will end up dying of a liver disease rather than liver cancer. And I strongly believe that especially, the BCLC-A, BCLC-B patients, I mean, they don't really die of a liver cancer per se. They die of a liver disease eventually. That's why we are, at least here, and I'm sure that other countries as well, our main focus when we see these patients are, and that's a patient with the cirrhosis and HCC, is always trying to most accelerate the liver transplant process on this patient, because eventually that's the savior of those patients. And also be mindful that even with the R0 resection, and presumably, if a patient can get resection, these are non-cirrhotic patient, right? So R0 resection, the reported 3-year the recurrence rate is 30 to 40%, but I think that is probably underreported. So patients' tumor recurrence are tremendous, but it coincides with the declining of liver health as well. So.
Yeah, because as you mentioned in a great talk, that the prognosis still remains dismal. So that is why maybe even if we are targeting the tumor and underlying liver disease is the problem, and we need to combine medications which may reverse some of the cirrhosis or fibrosis along with it.
You're absolutely correct. Of course, liver regenerating drugs and/or liver health drugs, if there were to be coming, that will be fantastic. But also, the part of our focus when we are treating this cancer is even beyond the Milan criteria, even beyond the UCSF criteria, since now we use all comers, the protocol, that our main focus on this cancer patient is not necessarily treat the cancer to save them, but more or less treat the cancer to put them into Milan, based on enhancement under the all-comer protocol, so that they can get liver transplant. So essentially downstaging, even larger scale than what we used to do before. In the past, when we were talking about downstaging, basically it's going from UCSF to Milan, right? But now we are taking everybody and trying to downstage them enough so that we can get transplant, because that's, we believe, that the only savior for these patients long term.
Thank you.
Just to further the discussion on this area, what Dr. Jalal asked, in child's B7 plus, especially, and in the child C patients, they're greatly limited by getting any sort of therapies. And do you think with the advancements of some of these techniques, for example, histotripsy, where you don't cause parenchymal damage, and even you preserve the arteries and the bile ducts while they're passing through, do you think there is a role of histotripsy in those particular patients?
So I completely agree. So it's two different things, and these are two different entirely diabolical sort of a concept. So one concept is child C patient with liver cancer of any tumor burden, whether it's a small burden or a large burden, should they be treated?
Mm-hmm.
And then if so, then how can we treat them, right? So, and these are non-transplantable patients. Because systemic therapy, by and large, including IO, the drug label is for child A patient. In fact, child C, I know it's still being used in some occasion, but it is supposed to be contraindicated and so on and so forth. But having said that, Child C patient with a small tumor burden or maybe medium-sized tumor burden, local therapy have been performed, especially ablation type, with little effects on the liver. As long as it can be targeted directly for small and the medium-sized tumor, they can do that. It can do that safely. Now, with the newer technology like histotripsy and so on, again, data is coming and maturing. I think that it's got a huge potential for doing that. So tumor local control, even in child C patient, I think can be done on appropriate patients. Having said that, if transplant is not available for child C patient, with or without tumor, as all of us know that the survival is dismal, whether such any treatment for cancer needs to be done, I think that's more of a bigger question.
No, I totally agree with you. But as the field is evolving, and I think, there was an era where we were not transplanting alcoholic liver disease patients unless they get 6 months of sobriety. But we got past that now. Similarly for cancers as well, and the advancements has taken us to the level that we are now taking all comers, with like downstaging and treating them and getting them transplanted. So it's evolving. I believe we'll be getting there, even to child C patients. Maybe some of those patients, not all, but I think a select group of patients will be able to make them a candidate by downstaging, even in the beyond that Milan I'm talking about, with these advancement techniques.
Yeah.
May I invite Dr. Mangesh Pragdala from Methodist? Dr. Pragdala, are you still there?
Yeah, I'm there. Thank you.
Yeah.
Dr. Kim, that was a great talk. Thank you so much. Just got a quick question in terms of patients who are downstage with multifocal HCC. What's your thoughts on using liquid biopsy in these patients as a guideline to who can be transplanted and whom we should wait for a little bit longer time?
So I don't know if it's a specific for unifocal tumor, maybe for other the more tumor burden patients as well. But
I'm just trying to mainly focus on, let's say, something like a portal vein invasion, which is like responded to Y90, and now it's a metastatic disease, technically LVI invasion. Now, would you, let's say it's been like more than a few months or maybe a year or so, would you then use liquid biopsy as a prognostic or indicator to kind of put these patients through a transplant?
Yeah, so that perhaps I can get help from others because the ctDNA or the liquid biopsy is only in infancy for liver cancer, right? I mean, I know it's being done for many other cancers, even colon cancer. I think it's becoming a lot more useful. But for liver cancer alone, that's HCC. I do not know the definitive data that is actually quite diagnostic. I know we order them. I know we get them. We try to reason with it and analyze it, but that's sort of where we are. We have not been, at least in our center, we have not been using it clinically just yet. Now, instead, of course, we use our conventional stuff, AFP, and essentially test of time. So as an example, the regular within Milan, outside of Milan, UCSF or whatever, we typically use, 6 months, and then we go to transplant. However, if it's a macrovascular invasion case that we downstage, or let's say infiltrative tumor downstage, we typically go for at least 1 year of a stability. And for us, that's the sort of a test of time to make sure that they will do okay after transplant. Now, if there's a liquid data that can do that better than the test of time, so that the good patient we can do a transplant even earlier, that will be huge. But to my knowledge, ctDNA is not yet clinical for HCC. Maybe I want to learn that from hepatologists here.
Another quick question is, I'm just the histotripsy was like something looked as the future for ablative treatment, and I'm just wondering why it hasn't picked up as of yet. Because you work in this field, you probably have more real-time data, like what's happening right there.
I'll be happy to discuss that, but maybe we can sort of close the loop on the ctDNA because I'm actually curious myself.
Oh, okay. So the ctDNA currently we use more for post-transplant than we do pre-transplant. And usually when patients have a higher tumor burden, anyone with HCC, in fact, at our center, we collect data on Signatera, usually with some of the liquid biopsies that we're using. And I've seen a pretty good correlation between the relapse of HCC, metastatic HCC with the positive Signatera. So it's got a lot of promise post-transplant, but we do not use it as a guiding test for starting chemotherapy without a foci or metastatic disease. But it's in its infancy stage right now, I can tell you that. But no
But
data
also, but also the post-transplant, I can understand it because you have a whole liver with you. But I believe that the pre-transplant on anybody else to be used, don't you need a PET sample to be able to get the ctDNA data, for which a lot of HCC patient is problematic because we don't usually get the PET on a lot of patients.
You're talking about tissue sample?
Yeah, correct.
Yeah, that's a good point. I mean, pre-transplant, you want to avoid doing as little biopsies as possible. But I'm just looking at some subset of patients who are going to be doomed. They're not going to get a transplant regardless because
No,
it's
what I meant
invasive.
is technically for ctDNA to be obtained for HCC patient, do they not need a tissue sample
Yeah, they do.
yeah, they do, right? So
Hmm.
in our center, pre-transplant, I don't know, probably 80 to 90% of our HCC patients, we do not do tissue biopsy. So for those patients, we can really order and get the ctDNA to be able to learn whether or not they're appropriate candidate for a liver transplant. That was my point.
Got it.
Yeah, I think that's the uniform across. In our center, we started doing more and more biopsies. Our oncologist has been pressing the need for that, just especially those who are uh, needing immunotherapies. We are making it mandatory to have a biopsy done, but not those who are not needing immunotherapies. But I think this is an evolving area. We don't do ctDNA routinely in our center. I think other hepatologists in the forum can comment on that as well. Um, uh, Otherwise, we'll move on to the next question that Dr. Prag will ask. Yeah.
Yeah. So in terms of a histotripsy, I think this is a very intriguing technology, being able, I mean, essentially non-invasive, right? Because it's not only ultrasound beam, the ablation, uh, without creating heat. Because one of the problem with the HIFU was that, because I sort of started my career with HIFU technology, so I'm pretty familiar with it. But one of the problem was it was a thermal technology. It was a thermal oscillation ultrasound technology. So that had a positive but also negative. But this particular technology is supposed to be non-thermal, so that's even better. The problem is twofold. One is a technical problem and one is a logistic problem. So the technical problem is you need to be able to see it, be able to treat it, right? What does that mean is that the lesion that is intended to be treated needs to be within the field of ultrasound visualization. And the original trial that got it approved was done for the lesions essentially in segment 6 or segment 3, because those are the below the rib, so you have a higher chance of being able to see it. And that was the only lesion that was actually included on that study, and that's intentional. But now it's approved, so it can be used for all the others. Now on sort of a thinner patient, on a sort of a more appropriate patient with the breathing control, you could see tumors in other parts of the liver. However, not as much, not as accurately as a CAT scan or the MRI and stuff, for sure. And then also bigger patient and patient with a fatty liver, patient who have a much bigger abdomen and stuff, and especially lesions above the liver is incredibly hard to see. And if you can't see it, you can't treat it. So that's technical issue. And then also there's a limit of a size, so that you can't really expect to have a good outcome for large tumors and so on. So that's another issue. And then the operator, of course, the operator needs to be trained and needs to be familiar with it. So those are the technical issue, as opposed to other ablation method, microwave, RFA, cryo. I mean, everybody, interventionalists, most of the people are very familiar with it. The logistic issue is currently the technology is pretty pricey. In the United States, I think they want to charge about $1.2 million for the technology alone. That's for the generator setup, and then there's a disposable cost, which is actually quite a bit as well. So the cost is not cheap, but those I'm pretty sure that they can be dealt with over time, and especially if good data were to be coming.
Kevin,
Thank
can you confirm that the histotripsy is approved by FDA currently for treating hepatic malignancies, all comers or only for non-malignant tumors? Because I thought that the initial trials were mostly on the non-malignant tumors.
So a lot of these devices gets a 510(k) rather than the disease specific. So just like other devices, this particular device got the 510(k) on soft tissue tumor ablation,
Yeah,
which is agnostic to tumor type, whether malignant or benign.
I see. Okay. Thank you. That's very helpful. Let me, first of all, if anyone else has any questions, please raise your hand or just keep your video on and ask the questions. Feel free to do that while I'm asking the other question. You mentioned, Dr. Kim, about the episcopal effect briefly in your lecture. So could you explain a little bit more on what's the mechanism for that?
I'm sorry, I missed the
episcopal effect, like we treat one tumor, I think, and then the another tumor, non-targeted tumor also disappear, I guess.
abscopal effect.
Abscopal, yeah, sorry.
Okay. Yeah. So abscopal effects are holy grail, something that a lot of us are quite interested in. It does happen, but it doesn't happen all the time, whether intended or unintended. And we currently cannot figure out why it happens on some patients, why it doesn't happen on some other patients. I mean, I don't want to label it as a myth, but because it definitely happens. I mean, it sort of started with it was a melanoma patient, right? Published in the New England Journal of Medicine, where a patient was treated with IO and they got some radiation in some field, and then everything sort of disappeared. And that made a big fanfare. Obviously that's truly a holy grail. But from my clinical experience, it doesn't happen that often, and that's probably shared by everyone, including radiation oncology people, who again are taking it as a sort of holy grail. But I've seen it with the Y90 radioembolization. I've seen it actually even with the ablations and so on and so forth. I can talk about it's similar to immune modulation that we are trying to do from a laboratory stuff, but there's far more unknown than known. In clinical practical sense, we don't see it that often.
Well, maybe one more final question about the evolving role of AI in the management of hepatic malignancies, where with the radiological tools that you're using. Is there something that you could light on?
Yeah, so the AI has, I think, changed a lot. In many fields, particularly non-medical. In medical, I think it's slowly coming. I'm sure that in fact, that this is a field that I need to learn far more on. But from my small sort of focused perspective, I am very interested in if AI can help us, both clinician and the scientists alike, but help us to what's the right word? To have a more regimented prognostic or even actually predictive values or inklings on our HCC patients. I mean, we use a lot of tools now, right? We use imaging, maybe a little bit of radiomics, AFP, patients' medical status, medical condition. I mean, we use all of those. However, a lot of it is experience. A lot of it is,
Correct.
our sort of clinical cues. But if there are ways that the AI can actually quantitatively tell us that what the accurate predictive factor will be before treatment starts, that will be huge for all of us.
Yeah, especially when we now have so many different type of tools available, and then choosing and the complexity of the care of the HCC as well, like single tumor, multiple tumor, location wise. Now, if you put an AI algorithm, which is basically human mind, you're doing it, but you as an experienced radiologist, and that's why your experience counts. Like somebody's a junior versus somebody senior. So, but there is a different level of expertise. But AI probably can predict and say, okay, this is the right way to approach, this particular patient, and would be very helpful. And maybe the outcome may be different. We don't know yet, but I'm just thinking about that.
You're absolutely correct. I mean, if you think about what the Google AI is doing in our lives and Amazon AIs, I mean, medicine is so far behind.
Yes. All right, I think we are way past our time. We started slightly late, 10 minutes late. So, I mean, we are right on time in that way, 1.5 hours, 1 hour, the lecture and then 30 minutes discussion. But thank you, everyone, for joining today and the patience and the engaging discussion. And Dr. Kim, particularly, thank you so much for your time. And this was a very exhaustive talk, a lot of information around, and it is not a particular HCC talk, so it's a lot of information that you had to put together and you curated so nicely. Thank you so much again for coming in and joining with us. And thank you, everyone, as well. And Happy New Year, and enjoy your rest of the weekend.
Thank you. Thank you so much. Honored.
Thank
Thanks
you.
a lot.
Thank you.